Evening to you all. Myself Solu Gautam, and today on behalf of Mero Eye team, I'll be hosting the current session. And I extend a very warm welcome to each one of you who have been connected with us through our iTalks webinar. Also, I would like to thank you all for taking the time out from your busy schedule and marking our program with your invaluable presence. Thank you for joining with us this evening. And also don't forget to subscribe our YouTube channel for being updated to our programs even in the upcoming days. For now, I would like to step forward to inaugurate today's session, and also I would like to notify you all that we will be having our discussion session at the end of the webinar. So if you get any queries in between the session, just drop them on our comment section. We will get back to you later on. Today, as a speaking delegate, we have Dr. Dirk Johan Booysen, all the way from South Africa, and he will be talking particularly about the pharmacology of contact lens practice. Before he begins, I would like to give his general introduction. Dr. Dirk is a DOptom, Fellow of the Scleral Lens Education Society, Fellow of the International Society of Contact Lens Specialists, and also of the British College of Optometrists and South African Optometric Association. He holds ocular diagnostic and therapeutic privilege in South Africa, Namibia, New Zealand, and USA. Currently, he is in private practice with part-time teaching position at several universities in South Africa. Also, he is an independent consultant to Bausch Lomb, Zeiss, Essilor, Genop Health, Alcon, and Johnson Johnson, South Africa. He has presented several papers in national and international conference. Also, he has published a textbook on clinical contact lens practice in August 2018. Over and above, the most interesting fact about Dr. Dirk is that he has private pilot's license with valid night rating and more than 1,200 hours flying time logged. I welcome you, Dr. Dirk, on behalf of Mero Eye Foundation and all our participants. Thank you so much for your presence, doctor. So now it's over to you.
I say Namaste, Ji, and thank you very much for inviting me to speak to you all the way in Nepal, a city, Kathmandu, that I would really like to visit one day. And so when COVID is over, maybe we can start. Thanks for the nice introduction. So without further ado, let's start with the talk. All right, so what we're speaking today about is pharmacology of contact lens practice. And in the pharmacology of contact lens practice, most of the pharmacology would be involved with the care systems that's involved with contact lenses. So the stuff that we use to clean the lenses, that we store the lenses in, et cetera, et cetera. So, you know, these things include preservatives, drug delivery systems, viscosity increasing agents, buffers, salt stabilizers, and a host of chemicals that are all involved in the care of the lenses. At the end of the talk, I will also speak a little bit about, or have a few case histories, because I think you need to be quite proficient in your pharmacology and also in your therapeutic treatment of eye disease or corneal or anterior segment disease when you do fit contact lenses, because you can induce some problems and you need to know how to fix them and sort them out. So this presentation that I'm doing with you today will focus on how these ingredients and all these solutions interact with the human eye. You will also notice on the side there that there's a photograph, and one of my students put this thing up there. He said, mention a textbook that made you cry. This is a textbook I wrote, and basically I wrote for my students, my final year students. So that's their book that they use. I've also said to the foundation that I'll send them some books that they can distribute along. As soon as COVID's over, we'll make a plan and ship them to you. All right, so before we start the talk on the ingredients of the stuff that we have in the solutions, let's have a look at biofilms. Now, biofilms are things that consist of polysaccharides, proteins, nucleic acids, lipids, and microorganisms. And these things are produced by the tissue and the fluids on the anterior segment of the eye, as well as the organisms they make themselves. Now, the biofilms adhere to any surface. whether it's a contact lens or the contact lens case, but very difficult for them to adhere to the front surface of the eye. But when we put a contact lens in there, we create an environment where the biofilms can start attaching. And what these biofilms then do is they create an environment for these organisms to thrive. So they protect the organisms from any of the disinfectants or biocides we use. And they also make the organisms resist pH variations, osmotic shock, and any of those things much more available. That's easier for them to resist all of that. So biofilms is a huge problem, and biofilms occur on any of the surfaces that we have in contact lens practice, whether it be the case or whether it be the surface of the contact lens itself. So one of the factors are that the surface hydrophobicity of the contact lens and also the contact lens containers are important. So different biofilms form on different types of materials. So it depends on if it's hydrophilic or hydrophobic, and different biofilms will occur in these things. What's very important to note is that the biofilms on contact lenses occur mostly on the posterior surface of the lens. So not on the anterior surface, but on the posterior surface of the lens. So what that means is that these organisms that reside in the biofilm are then in direct contact with the epithelium. And if you do have a small epithelial break, it's very easy for these things to cause infections. So the organisms that we find there include Staphylococcus, gram-positive bacteria, Pseudomonas, Serratia. All of these things are there. So they form these little cities, if you want, where they're quite happy to live, and they can cause severe problems if we do not take care of them. Reinerson in 2016 came up with a mechanism which involves biofilms and the pathogenesis of blepharitis and dry eye disease. And I'd just like to spend a moment and just discuss that before we go any further on this. And they call this DEBS, or dry eye and blepharitis syndrome. And what these guys said is that if you think about what dentistry did 100 years ago, roughly, they started having people clean their teeth. So they removed the biofilms. And what that meant or managed to do is to reduce the infection rate or tooth decay rate in dentistry. So what Reinerson did is he went and looked at the lid margin and looked at the biofilms that occur in the lid margin, and then looked at decades of damage that occurs to eyelids due to biofilms. So in stage 1, for instance, in his situation, the lash follicles are involved, then the meibomian glands in stage 2, and the rest of the eyelid is involved in different parts of it. But these biofilms take decades to cause the damage. So it's very interesting that these guys have proposed that we just make a plan and clean the lid margin, and maybe we can get rid of a lot of the meibomian gland dysfunction and blepharitis problems we have, as well as dry eye syndrome, which is a very interesting theory. And we started doing it in practice and actually found that it makes quite a big impact on our patients' well-being. So biofilms are what we are intending to get rid of on contact lenses. Now, very importantly is to also think about some of the newer solutions that are being introduced on the market is not necessarily intending to get rid of all the proteins that are formed on the lens surfaces from your tears, but to stop these proteins from denaturing. Because remember, your tear layer has a numerous amount of proteins that are specifically designed to kill bacterial organisms in there. So some of the newer contact lens solutions saying, okay, well, maybe we shouldn't get rid of all the protein that are natural, but protect those proteins to keep them in their natural state so that they can be bioavailable and kill these organisms. So what preservatives do we have? You all know about Benzalkonium chloride and Polyquats and Thimerosal, chlorbutanol, sorbic acid, methyl propyl parabens and chlorhexidine and disodium ADTA. So all of these things have a function in the solutions, and some of the solutions will have multiple of these preservatives which is intended to kill the microorganisms that are present on lens surfaces. I've just put a table together to give you an idea of what some of the products that we have available. So these are all artificial tears that are available in South Africa. So if you look down the left-hand side of the column, they'll show you the names, which is Refresh Plus, Refresh Tears. And on the far right, the preservatives that are involved in these. Pure Right we'll discuss a little bit later. That's one of the newer preservatives. But you can see they've moved away from things like benzalkonium chloride, because people tend to put these drops in their eyes very frequently. So you want to start going away from preservatives rather than have preservatives in there. And we'll discuss why that's important just as we go along. There's some more stuff, TheraTears, Sustain Ultra. I'm not sure what you have in your country, but I'm sure it's very similar to this, maybe some different names. But this is what's in the stuff, and you can see the preservatives on the right-hand side. Here's some more artificial tears, Zeeland, which is some of the newer stuff we have in our country, and you can see what they preserved with. And now we start looking at, say, some of the products that we use to clean lenses. So we've got OptiFree, Aosept, which is a peroxide-based system, then Polyrinse, which is saline, Renew, multi-purpose, which is Bausch Lomb, BioTrue, which is one of the newer solutions, and this is one of the ones that they are saying actually protect the proteins in the tear film or on the lens from the natural proteins from denaturing, like lysozyme and lactoferrin and those things. Then Oxycept, another peroxide-based system, and the Boston stuff at the bottom, and mainly used for hard lenses. But this is very much what we have, and you can see what is in there. Something like Aosept, which is hydrogen peroxide, has no preservatives because it self-preserves. I mean, it's so strong it kills anything that gets in contact with it. You look at OptiFree, it's got Polyquat and a combination of Polyquat and EDTA, and we'll discuss these in more detail as we go along. So what's in the stuff? We have buffers and salts, we have preservatives, we've got surfactants, we've got chelating agents, we've got wetting agents, peroxide, and enzyme cleaners. So what is the role of the buffers and what do they do to pH? So the pH of most solutions vary between 4 and 8.5, and we know neutral pH is 7. And if you want to go alkaline, you go over 7, and towards 14 is very alkaline. And the lower you go is more acidic. So pH limits for epithelial damage is less than 4 and no more than 10. If it goes less than 4 and it goes more than 10, you're going to have epithelial cell damage on the cornea. The buffers are used to keep the solution pH stable. And there are things like sodium phosphate, borate, thromethamine, and bicarbonate are typically the buffers that are used. So when you have a buffer, the buffer is there to look at keeping the pH in an acceptable range. Low buffering means the pH can change quickly when the solution is introduced in the eye, and high buffering keeps the pH constant. So some drops will have a buffering system which, when you put the drop in the eye, it'll quickly go to what the eye's pH is, so it doesn't burn as much, and others may have a high buffering, which the pH is kept more constant. The most common alkali solutions, high pH, tend to be the ones that are more buffered and changes the least. Now, salts like sodium chloride keeps the solution isotonic and maintains the osmotic pressure, and solutions differing by as little as 0.2% sodium chloride can have an effect on the corneal thickness and the comfort. And we know that. If you put a 5% saline solution in the eye, you in actual fact can draw some fluid from the cornea. So if you have eye drops or something like that, you can actually treat that by using a 5% saline solution. So I just want to mention something by a chap by the name of Abelson, Dr. Abelson in the United States. And he made an analogy that an epithelial cell is like a goldfish in a bowl. So an epithelial cell is only happy when its environment is exactly adapted to it. If it's not an environment that's conducive to its happiness or its life, it'll die. So what does it need? It needs oxygen, metabolism, nutrients. The pH need to be right. The osmolarity needs to be right. Proteins and defense mechanisms on the front of the eye, which is defends or protects the epithelial cells. Antioxidants and free radicals are there, and they can damage cells. And you need to remove the toxins from that water. So think about an epithelial cell as you think about a goldfish in a bowl. If that environment is not good, that cell will die, and then you'll start having problems with infections and microbial keratitis, for an example. So this slide says preservatives is the necessary evil. So these things are considered the culprit in damaging the corneal epithelium, and especially the glycocalyx, which disrupts the tear film, and that can lead to ocular surface disease. Now remember, the glycocalyx is produced by the epithelial cells, and it sits between the microvilli of the cells. And that glycocalyx structure is what holds the whole tear film on the front surface of the cornea. If the glycocalyx or this scaffold structure is damaged, the tear film will be disrupted, and that you'll have then ocular surface dryness, dry spots. Once that starts, there's a host of other problems that follow. So preservatives restrict or inhibit the growth of microorganisms. All preservatives are toxic, and the toxicity is dose related. In the eye, the preservative turnover is very low, okay? And they can be retained in the eye for up to 7 days. Some of these preservatives are lipophilic and bind to the tissue, others are not. And remember, when you have things that can stay in your eye for 7 days, if you're going to put a repeated dose in there, you're going to have a cumulative effect, and there can be a prolonged exposure of the epithelium to these things. So the other problem we have is we have to have this concentration effective to kill the microorganism, but we don't want it to be toxic to the ocular surface. So it's a very delicate balance that you have to have. So there's two mechanisms of actions of the preservative. So the one is a detergent action, the other one is an oxidant action or antioxidant action. So when the detergents or the stuff that works on the detergent base, they alter the cell membrane's permeability of the organisms, and that's why they'll kill them. Where the oxidants, in actual fact, they'll disrupt the metabolism in the organism cells, although they also have a small effect on the cell membranes. And detergent includes things like benzalkonium chloride, polyquatronate, alcohol preservatives, and phenols, where the oxidants are stabilized oxychlorocomplex or SOC, sodium perborate, Thimerosal, sorbic acid, and chlorhexidine. So if we look at the different preservatives that we have, you can actually see Thimerosal is probably the most potent one, which is no longer used. Then you get back chlorombitinol, Polyquats, L-dox, sodium perborate, and EDTA right at the bottom. So the stronger they are, the better they work, but the more effect they have on the cornea. This is basically what this little slide tells you. So when you look at benzalkonium chloride, which is very common, and they use it specifically in anti-glaucoma medications, which I'll allude to a little bit more later on. This is a quaternary ammonium compound, and it's found in concentration between 0.004 and 0.01%. It's extremely effective in combating microbial contamination, including necrosis and cellular apoptosis, or disrupting the cell membrane and bacterial cells. So it's very potent. It's one of the detergents. But BAC has also got some very negative effects. And if I show you there, it interferes with the lipid layer of the tear film, and it reduces the tear breakup time and tear film stability. So when you're starting to use artificial tears, for instance, with benzalkonium chloride as a preservative, you're not really making much sense, because it is going to cause problems with the lipid layer. It also has effect on corneal health, and specifically on the epithelial cells. That has an effect. It messes up the barrier function, so the cells are not stopping stuff from penetrating into the cornea. It also reduces the healing, and it increases drug penetration into the cornea, which is useful in glaucoma treatment. So some of the glaucoma drugs use benzalkonium chloride to, in actual fact, make the drug more, or make the drug penetrate through the cornea better and to get into the anterior chamber of the eye, where in actual fact needs to do its job. Benzalkonium chloride also has effect on the conjunctiva. It increases inflammatory reactions in the conjunctiva. It messes up the goblet cells, so your mucus secretion is affected. and it affects the contractility of the fibroblasts in the cornea, which may lead to shape changes in the cornea. It's dose-dependent disruption of cytoplasmic membranes and cell detachments. It's dose-dependent swelling and desquamation of superepithelial epithelial cells, and it causes apoptosis. And it can also be absorbed into contact lens materials, but not PMMA. But some of the other stuff out there, you know, especially your hydrogel lenses, it can go into those lenses and stay inside there. Remember, as I said previously, some of these products can stay in the eye for up to 7 days. How long do they stay in the lens? I'm not sure. The next one that's available is chlorhexidine. And it's a non-irritant bactericide of low toxicity, effective against gram-positive bacteria, but it's not active against spores. So it's not going to work really well against spores. It's efficacy against Proteus and Pseudomonas is low, but improves if you add something like EDTA or any of the other products out there, you know, so these things can get better. As long as there's no organic matter such as serum or phospholipids, which reduce the efficacy, you can use this. This forms soluble salts with bicarbonate, borates, carbonates, citric phosphates, sulfates. So it can't be used in any eye drops containing sulfates or atropine or neomycin or physiostigmine and zinc. And the kill time is low. With low concentrations, can be up to 10 hours. Now, I don't know any of my patients these days, especially the younger guys, that leave their contact lenses for 10 hours. Some of them sleep less than 4 hours a night. So it's not going to help them much. And this is considered to be an antioxidant. I'm sorry, let me just get this going again. Now my slideshow has stopped. Sorry, guys. I'm just trying to sort out this computer of mine. Maybe it'll work now. There we go. Okay, the next one is chlorbitanol. This is an alcohol-based disinfectant or preservative. It's got no surfactant action, so it doesn't clean when you rub it. The method of action is cell lysis, and it disrupts microbial cell membranes. It does not affect the lipid layer of the tear film. It's less toxic than BAC, and toxicity occurs less rapidly. And it can be used synergistically when you combine it with things like benzalkonium chloride and polyquat, and it's considered to be a detergent. Now, Thimerosal is no longer on the market, but I put it in here to show you what I think some of you that might be as old as I am might have seen what this stuff can do to eyes. So this is a mercury-based type preservative, which is antimicrobial due to the mercury that's in it. It acts through intracellular calcium mobilization, and it was used in concentration between 0.001 and 0.002% in both hard and soft lens solutions. Highly potent antimicrobial, which is up to 40 to 50 times more effective than if some of the other stuff against Staph aureus, which is a very common bacteria. It's considered. In the 1970s, it fell out of disfavor because of the neurotoxicity that you get with mercury. And there was a concern about the metabolism of the methyl mercury, especially regarding things like autism and vaccinations that contain thimerosal. So it remains a contentious issue to this day, but be as it may, it fell out of favor. It also appears to cause an allergic response, and it's been reported as one of the most common contact lens allergens or contact allergens in the population. It's slow acting and frequently used in combination with chlorhexidine. And as I said, FDA banned thimerosal and other mercury-containing agents in the 70s. So what did we see in the 70s with thimerosal and solutions? Well, thimerosal, as I said, works like a hapten. It's a partial allergen and induces delayed hypersensitivity reactions. So we saw things that looked like superior limbic keratoconjunctivitis. We had very red eyes. We had limbal follicles. We had GPC or giant papillary conjunctivitis, corneal infiltrates, superficial punctate keratitis, and very importantly, things that look like dendritic ulcers on the cornea. and they had epithelial opacities and even new vascularization. And when you took the thimerosal away, these things went away. And that's why they found that it was a direct link between the thimerosal and this. So can you imagine seeing your patients come in with a thing that looks like a dendritic ulcer when they wear a contact lens and you're not sure what is actually going on and trying to treat them? It became quite a nightmare. So this stuff is no longer available, thank goodness. Some of the newest stuff on the market is Polyquats. Polyquats very commonly used in solutions that we use for contact lens cleaning and storing. And it was originally used as anti-malarial for water treatment and swimming pool disinfections, cosmetic preservatives, antifungal water-based inks and industrial disinfectants, and antibacterial wipes. So people use this in their swimming pool to keep the water clean and pure. It's the same family as chlorhexidine. The molecular size and weight is larger, which prevent penetration into soft contact lens materials, which sounds quite good. So in vivo studies have shown ocular toxicity and corneal breakdown of interepithelial cell junctions with Polyquat, although much less so than with BAC. Okay, the tendency to reduce the number of conjunctival goblet cells, and that messes up the tear layer. There's less mucus and aqueous production is also affected. And it's frequently used with current generation of multi-purpose solutions, wetting solution, artificial tears. And it's considered to be a detergent. So when you start looking at these solutions, this is what you're going to see quite often in some of the stuff that are available on the market commercially now. Cationic and therefore effective against gram-positive and negative bacteria. It works by binding to phospholipids in the cell membrane, so it messes up the cell membrane, and that's how the cells are killed. It can be effective against fungi and acanthamoeba, but you have to combine it with one of the other preservatives to enhance effectiveness, and its concentration is quite low. Another one is EDTA or disodium. I'm not going to say that word, I'm going to mess it up, so we'll just talk about EDTA. It's known as an ionic chelating agent. It disrupts the integrity of the cell wall, so accelerates, it kills the cells by messing up the cell wall. Its concentration is low, especially effective gram-negative bacteria cell walls because of the liposaccharide structure, and is used with other preservatives, antibiotics to enhance the effectiveness against aeruginosa and E. coli specifically, and it's also a detergent itself. Another one is imidoamine, and Aldox, or what's called Aldox, is a cationic surfactant effective against fungi and acanthamoeba, and it also interacts with the cell wall, so allow penetration. It's quite toxic and normally cause some degree of ocular discomfort and tissue damage. But these will be combined with some of the other preservatives like EDTA or Polyquat or whatever there is out there. And then you get sorbate or sorbic acids, limited microbial activity. And these things are used for sensitive eyes and the solutions that are marketed for sensitive eyes. It passes through the plasma membrane, dissociate the cytoplasm, release protons, inhibit growth via acidification in the bacterial cell itself. Adverse reactions are infrequent, but you can get a punctate keratitis. And then something called Gen Aqua, it's some of the new ones, sodium perborate. It's oxidative preservative and it's commonly used in dry eye products. It's effective against numerous bacteria as well as aspergillus, which is a fungus. And it combines with water. It's converted to hydrogen peroxide. Now, your body is quite effective in actually neutralizing hydrogen peroxide. So this Gen Aqua is marketed as when it gets in contact with the tear, it dissipates, and in actual fact, it becomes harmless to the tissues of the eye itself. It oxidizes cell walls or membranes and affects the membrane brown enzymes, disrupts cellular function, it's protein synthesis. When it enters the eye, it decomposes the water and oxygen. So it's marketed as a soft preservative itself, and it's quite common in your newer products like your dry eye products itself. The other one is called Purite, or SOC. It's also one of those that that dissipates by converting products normally found in the tears, so like sodium ions, chloride ions, and oxygen and water. It's gentle and it's ideal for chronic use. It's efficacious and its concentration is low as 0.5. It's not yet used in glaucoma medications, but available in dry eye products as well as contact lens solutions itself. And it's effective against many types of bacteria, aspergillus, and some viruses, but they don't really know how it works. So it's one of the softer things. And you'll know if you look at the products that they sell on the market, they market Purite as an actual fact, when it comes in contact with the tear film, it converts to stuff that's normally found in the tear film. So when it's in the contact lens container with a lens in there, it keeps everything sterile, or if it's in the bottle, it'll keep the stuff sterile. But once it gets into the eye, it changes to become less toxic for the tissue itself. There's a new one called Zofzia from Alcon, a new proprietary ionic buffet solution, which has got boride, propylene, alcohol, and sorbitol in, and these things are not in themselves significantly toxic to the surface. It's biocidal activity against the 5 required organisms. It was tested against some other stuff as well, and it found that it does kill them. And then the fungal challenge test showed that it steady decrease in surviving organisms over 14 days. So Zofzia is one of the newer ones as well that we'll probably see coming on the market more readily and more in solutions itself. And then we can look at surfactants. Now, the surfactants are there to clean the surface of the lens. And these things are important to remove biofilms. I'm not sure what it's like in Nepal, but in our country, one of the companies marketed a product as no rub. So they market a soft lens solution that you actually just put your lenses in a container, and that was supposed to then kill everything that's on the lens. So when the next time you wear the lens, it'll be fine. Now, I think it's a no-brainer. If you don't rub a contact lens, you cannot get rid of the biofilms, and you actually need to disrupt these biofilms to actually get rid of them. So surfactants actually do that. So they remove these the biofilms from the lenses. They disrupt the surface tension and they are amphiphilic, which are both hydro and hydrophilic, and they chemically attach to the biofilm. So when you rub the lens between your finger and fingers itself, it'll actually rub the biofilm off. And once the biofilm is disrupted, you can then get the preservatives that are in the solution to get to these organisms that hide in the biofilm, if you will, and in actual fact get rid of them and have a much more effective kill rate. So please, if you have contact lens patients, make sure that they learn how to rub their lenses. If they don't rub their lenses, they're not really making any impact on them. So it's very important to rub and rinse your lenses. And then we have demulcents and wetting agents. And these things are there to enhance comfort. And you'll see a lot of new products come on the market now, which will try and get the lens surfaces wetter. So one of the things in South Africa that happened, and I think most of the world, is that people moved away from hydrogel lenses going to silicone hydrogel lenses. Now we know with silicone doesn't like water. So silicone tends to be very dry on the eye, and a lot of time and effort has been spent in changing the surface of the lens to make it more wet. So you can also have solutions that have the wetting agents in them to try and keep these surfaces of the lenses wetter. And I think Alcon has recently marketed some new stuff which they claim to in actual fact enhance the wetting angle on the lens itself in their solution as well as on their lenses. So those are what they are for, and they consist of things like polyvinyl alcohol, povidone, tetronics, polysorbate, and all of those type of things. The other one that's quite important and I use often in practice is hydrogen peroxide, and I put this completely on its own because it's not really a preservative. Hydrogen peroxide is self-preserved. So a 3% hydrogen peroxide eliminates a variety of microorganisms, including bacteria, fungi, yeast, spores, viruses. It's self-preserved and unaffected by organic matter or salts. Can penetrate biofilms, and 10 minutes of exposure will kill most bacteria. Hydrogen peroxide is lipid soluble and it penetrates the cells easily. And then it produces hydroxyl-free radicals that attacks the organism's lipid membrane, DNA, mitochondria, and other cell components. And these free radicals exist for a short time, and the human body is accustomed to dealing with peroxide. So it's quite easy to sort it out. So as long as the peroxide is neutralized to less than 20 parts per million in a 6-hour period, you will have very little side effects with this. But you'll always have somebody that'll put the hydrogen peroxide directly in his eye, and that will lead obviously to a corneal problem. It'll kill readily the epithelial cells as it does the bacteria. In my practice, I use hydrogen peroxide often. I even use it with scleral lenses as well as RGP lenses, and we have very little issues with it because it's so good. The only problem that we have sometimes is that the stuff that they use to neutralize hydrogen peroxide over the 6-hour kill period is sometimes not that effective. So the other problem that I mentioned earlier on is that some of our students or young people maybe don't sleep 6 hours a night. So if you give them a hydrogen peroxide system, when they take the lenses out of that container and put in their eyes, it's going to burn them. So we're probably going to find some new stuff coming on the market with a shorter period of time with a high kill rate, and it'll be neutralized in shorter time periods. And hopefully that'll become available on the market soon. Okay, so let's do some case histories. So if you look at this case, and let's say this is a contact lens wearer, and they come into your office with a slightly red, painful, sore eye, but no discharge or anything like that. And if you look at that cornea, this is the same eye, and you can see different little things happening there. So if you look at the left-hand top picture, what you'll notice is a little infiltrate right at the top, just below the lid, at about the 1 o'clock position, a little bit in from the limbus itself. And if you look on the right-hand picture on the side, you'll notice there's some staining happening there. And if you go down a little bit and you look in other areas, there's obviously some more infiltrates there. So this typically is something that we see very often, and we see it often when people have blepharitis or meibomian gland disease. And why do we see it there? Because there's staphylococcus bacteria that live amongst the lashes and around the meibomian glands. And this is not an infection. In the old days, we would call this a sterile ulcer, because you've got an infiltrate which is not really staining. So there's not an infection going on. There's an irritation going on in the cornea. So the staph bacteria would produce toxins which is secreted into the tear film, in this case where there's a contact lens patient, and that would irritate the cornea. So you'll have an immune reaction take place, and you'll get the white blood cells migrating to that area, and that would then lead to an infiltrative reaction, and then you'll get this type of mild red eye with a little bit of discomfort. Often these patients are not even aware of this. So how would we treat this? Well, the first thing is to find out what the reason is. So I would call this a staph hypersensitivity reaction. So you need to clean up the lids. So you need to get rid of the blepharitis and get rid of the bacterial biofilms that are on the lid margin. So what we'll do is do an eyelid hygiene regime where we would clean the lids. We'll use hot compressors with the patient, and they'll do some expression of the meibomian glands, and then we'll clean the lid margins. And in recent times, we've got a product called hypochlorous acid, which we actually use now in preference to anything else to clean eyelids. Now, hypochlorous acid is an interesting product because it's something that your body manufactures on its own, and it kills the bacteria quite readily, but it doesn't kill all the bacteria. So it tends to maintain the normal flora of the eyelid while getting rid of some of the stuff that shouldn't be there. Once you've done that, you know now the lids are clearer and going on, we need to clear up this problem that we see on the eye itself. Now, in this specific case, we'd use a steroid antibiotic combination. In our country, we've got something called Specifics Co, which has got chloramphenicol and decamethasone, or you can use Tobradex, which is tobramycin and decamethasone, or Maxitrol, which has got neomycin and some other antibiotics as well as decamethasone. Or you can just use an antibiotic drop as well, which will take longer to heal. Remember, that's mainly an inflammatory action that you're looking at. So you want to clean up the inflammation. And this specific patient, we use the Specifics Co, and this resolved very rapidly. But the important thing here is to, in actual fact, make sure that you get the root of the problem, and which is the blepharitis, in this case specifically, that you need to sort out. This is much the same sort of thing. This is just a more severe case. And you can see on the right-hand picture, there's even a hordeolum on the inferior lid, which would then cause a lot more problems. So you actually really need to go after these and sort out the lids, because if you don't do that, it's not going to get better very soon. So another case, this lady came into our practice, oldish lady, and she had very big discomfort in her eye. And if you look at the color photograph on the left top, you'll notice that there's a lesion on the cornea. And when you stain that lesion, it looks like it's in actual fact a large area that there's an epithelial defect. And if you look at the bottom picture, you'll notice that in actual fact, it lies exactly where the two lids meet. So she might be sleeping with her eyes open and cause a bit of a recurrent corneal erosion syndrome. So this specific patient was diagnosed with keratoconjunctivitis sicca. So she's got severe dry eye. So you actually have to protect that cornea. So what do? In her case, we use the bandage lens. And whenever I use a bandage lens on a patient like this, because the epithelium is disrupted, we need to protect it from getting an infection. So we gave her fluoroquinolone with an Exocin is what we used in this case. So we put a bandage lens on, use the fluoroquinolone 4 times a day. And we also added FML, which is a mild steroid, just to get rid of some of the inflammatory action. And you need to keep that bandage lens on the eye for a while so that this lesion can resolve itself properly. Otherwise, you've got trouble. We also cleaned up her lids. We did a lid hygiene regime on her. So we did the same thing, hot compresses, expressing the glands, and cleaning the lid margin, so that we can sort it out. And that we use hypochlorous acid for in her case. There's another very interesting case. A lady walked into my practice on a Monday morning with a history of cleaning her ceiling at her house. She had a dirty spot on her ceiling, and she decided she's going to use ammonia to clean the ceiling. This happened on Saturday. She got the ammonia in her eye, and then she went to the emergency department at the local hospital, where they gave her something called Maxitrol, which is decamethasone with some antibiotics. It's an antibiotic steroid combination. So on the Monday morning, she presented like this in our practice. So the first thing you need to think about is there an alkaline burn here? And alkaline burns are very hard to treat. In her case, fortunately, it wasn't the case. So what we did it's alkaline solution, but what we did with her is manage her conservatively. So the first thing we did with her is copiously rinse that eye. Half an hour to an hour of rinsing with saline. Just get rid of whatever is in there. Clean the fornices out and the whole story. The next thing we did with her is we used the cycloplegic to paralyze the accommodative system as well as the pupil. So to get rid of some of the pain for her and to prevent an anterior chamber reaction itself. Okay. And then what we did is we put a bandage lens on her eye, and we used a fluoroquinolone drop, Exocin, nothing else, just that, and then followed her. So you can see day 2 and day 6 until resolution on the right-hand side. So it takes a while for this thing to heal itself. We were lucky in this case that there was no further damage itself. The problem with using something like a steroid in cases like this, a steroid delays the healing of the epithelium. So if you don't need to use a steroid, try and avoid it if you've got a large abrasion or large defect of the epithelium, because it will slow the healing process of the epithelial cells. It's not wrong to use a steroid, but just be aware that it can slow, you know, the resolution of the problem itself. And she was lucky. We got lucky. We helped her quite nicely. And I don't think she'll do something stupid like cleaning her ceiling with ammonia again. It's another case that walked into our practice. And in this specific case, if you look at that, our differential diagnosis here, something like a pterygium, a pinguicula, episcleritis, foreign body, anything like that. In this specific case, it was an inflammatory pterygium. Now, how do we treat this guy? We treated him with a steroid. We used the steroid in this case and got rid of the inflammatory action to try and get that thing down. And once it's sort of resolved, we had a chat to him and got him to go for surgery to have it removed. The pterygium is very common in Africa, and especially the closer to the equator you go in Africa, the more you'll see, because our incidence of UV radiation is quite high, and people tend not to like sunglasses that much. So they walk around with these things and they're outside in the sun a lot, so they do have this. What are the risks of these things? You know, because it's sitting right next to the cornea there and it's this elevated mass that sits there, you can develop something called a Dillon, which we'll discuss a little bit later. I think we have a case on this. So in this specific case, think about your differential and start treating it, and then get them to get the surgery when everything is resolved a little bit to get better, and advise them to wear sunglasses. You know, they tend not to want to do that often. There's another case, and this is specifically somebody that came in. And if you look at that eye, you in actual fact see on the left-hand picture, there's like an excavation of the limbal area itself. And when you stain it, you've got all the fluorescein pooling in there. And this is a case of Dillon. Right, so this is a dry spot that develops next on the limbus itself, and probably due to an elevated area on the conjunctiva. So how do we manage this? In this specific case, also managed it with a bandaged contact lens and just a fluorometholone, fluoroquinolone, antibiotic drop, just to make sure that there's no infection when you put a contact lens on there, because God forbid you make it worse. And then also a lot of lubrication, and try and find out where the problem is. Look at that conjunctiva and that area very carefully, because there's a reason that that thing is occurring there. And you can see there's the contact lens on the eye itself, closing that area. And you can see after a few days how that area is resolved and how that lesion has sorted itself out. So you can do a lot of these things very simply by just thinking logically about what the trouble is. Here's another case. This is a colleague of mine, a young guy, I would say he's young, he's in his 30s. He had bilateral keratoconus, and this is a eye drops in his one eye. And interesting with him, he eye drops the weaker part. So both his eyes was like this within a week of each other. And as I said, he's a colleague, so he had to carry on working. So we had to make a plan and treat eye drops. Now, in the old days, eye drops were seen immediately as that needs to have a corneal transplant. In my practice, we've managed eye drops quite carefully, and sometimes when the scar that remains afterwards is outside of the pupil margin, you can get away with really good vision. So the cornea tends to flatten off a little bit, and they go well, and they actually see quite well, and it makes your contact lens fitting a lot easier. The trouble is obviously, you know, immediately for them, it's quite a mess. So they're uncomfortable. They sometimes have a bit of pain. And you can see the epithelium is very rough. So you also have to think about, you know, preventing secondary infections. So how do we treat this? Now, in the old days, historically, people used the 5% saline solution to try and draw the fluid from the cornea. Now, recently, some work has been done in this field. And we're also busy with a study through the University of the Witwatersrand now, where we're actually examining another way of doing it. Because the thinking is that if you put sodium, a 5% sodium chloride solution in the front of the eye, you're actually setting up an osmotic pressure that pulls the fluid into the cornea, and more fluid pulls in from the anterior chamber into that defect in the decimase membrane, and you get more swelling. So the latest way of thinking about this is we treat them slightly differently. So what we would do in this case is use an anti-glaucoma drop. And we'll use something to drop the pressure in the front surface of the eye and actually stop the fluid from ingressing into the cornea. And we've had these guys resolve within 3 weeks, which is unbelievable in some cases. Sometimes they take longer, depending on how big the lesion is. But in the old days, it used to take 3 to 6 months. Now we can change them in 3 weeks. So what we'll do is you'll use an antibiotic, typically a fluoroquinolone in his case, just to cover him that he doesn't have an infection. And we'll give him something like Diotrav or Zalatan or Zalacom, just to drop the pressure in the front chamber of the eye. Surgically, you can also treat them by injecting a bubble into the anterior chamber that actually just flattens that area and stops the ingress of fluid into it itself. So you can have an intracameral injection of gas into the eye that will actually stop, the fluid getting in there. But if you don't want to go that far, you can try the anti-glaucoma drops. Just a word of warning though, don't use a carbonic anhydrase inhibitor, because that messes up the endothelial pump. So you don't want to set up more trouble than you have already. Use something like a prostaglandin with a beta blocker. That works quite well and it's fairly safe. And then with beta blockers, make sure he doesn't have asthma, because you might just kill him if he has asthma or some COPD or something like that. So he did quite well. He hasn't had a corneal transplant. This is about 5 years down the line now. And he's wearing a normal RGP lens, and he gets, and this specific guy can get 6.9 in the one eye and 6.75 vision, or 20/25 and 20/30 vision with the eye drops. As you can see, the scars just at the bottom edge of his pupil, and he's been lucky. So he didn't get a transplant. He's still with his own tissue, and he's very stable. This is just a tricky one that I put in, and I always put this in for my students in their exams. And they look at this and they think, well, there's a big problem here. It looks like an infiltrated keratitis or something, but this is just a contact lens that's very dirty. So the surface of this lens is shockingly dirty. This is a patient that doesn't rub and rinse. So it's just a tricky one that I put in. And then I think this is the last case that we have. These are quite common, especially in our country in winter months where we have a lot of flu. This is an epidemic keratoconjunctivitis, and it's caused by adenovirus. And this one has specifically got membranes. And you can see this big, thick membrane in the bottom of the lid that interferes with the cornea itself. So when you get these viral infections, they get these membranes that are very thick. And if you don't peel those membranes off, they're very, very uncomfortable. Sometimes viral infection or adenoviruses don't go as far as this, but they are self-limiting, can resolve within 7 to 14 days. The issue here is we can't kill the virus, so we have to give them palliative treatment. And what would you do in this case is to try and make them comfortable and prevent secondary infection. So you'll use a steroid with an antibiotic combination typically and just follow them. If you look at the bottom left-hand picture, you can actually see the infiltrates in the cornea, and these are called subepithelial infiltrates, which are caused by this virus. And these things can stay in the eye for a long, long time. In some cases, even up to 2 years. And if they're as dense as those are, they will interfere with vision. So just, advise the patient that sometimes these things can stay there for many, many months. And if you're a contact lens practitioner and you're seeing a patient for the first time and you see these little infiltrates, then know that he's had an episode of this. If you turn the lids over where these membranes are, and if they've really been bad, you'll have a lot of scarring as well. And remember, at night, your cornea gets its oxygen supply from the back of the lid. So if you've got this thick membrane, gooey stuff sitting behind the lids, how's that cornea going to function? It's really uncomfortable. So you have to peel them. And then another word of warning, they're very infectious. So be very careful to wash your hands. Not that I have to tell you to do that with the COVID epidemic that we have now, but be very careful. These things are not called an epidemic for nothing. They tend to spread rapidly through the community. And that's it. Thank you very much. Any questions?
Thank you so much, Doctor, for such a wonderful presentation. Well, now it's time for the discussion session to begin. Are you ready to take the questions, Doctor?
I'm ready.
Yeah, I will read out the questions for you. Let me
Okay.
check out the questions that our attendees might have raised. Okay, we have first question, and the question goes as, what are the most common infection causing agents in South Africa and the medication used against it?
Well, the most common things we have here are typically staph. If you talk about corneal infections, it's normally associated with Staphylococcus bacteria, Staph aureus. So that's really, really common in our country. We do have an incidence of Pseudomonas, but and especially when you're working with contact lens patients, you must always be aware that Pseudomonas lives in these biofilms. So if you have an epithelial defect on the cornea, and you're going to treat them, you must make sure, if it's a contact lens wearer, that you cover them for gram-negative as well as gram-positive. But what we commonly see in South Africa in terms of infections or bacterial infections is staph. Saying that, most of the pink eyes or red eyes that we see are normally got a viral component to it, and they are normally adenoviruses that we see. So, as I said, when winter time comes around and people have flu and colds, these viruses then can cause, viral keratoconjunctivitis, and we do see them commonly. But Staph aureus is probably the most common bacterial infection we see. And then we do have a few Pseudomonases, and thank goodness we don't often see acanthamoeba infections, but we do have nowadays got some problems with water supply in some areas, which we might end up seeing a little bit more of that, but thank goodness not so many.
Okay, doctor, we have another question, and the question goes as, what are the mainly used medications if patient come with epithelial defect on your country?
So the common, let me just get the question straight. So what do we commonly use if a patient has an epithelial defect? Is that the question?
Yeah, doctor, that was the question.
All right, so in my practice, certainly what I would like to do is, it depends on what the epithelial defect is caused by. As I said, if it's a contact lens patient, I would use a fluoroquinolone, one of the first generation fluoroquinolones like Exocin or Ococin, or one of those things to treat them. If it's not a contact lens patient, I will use something like chloramphenicol, which is used in South Africa quite commonly. That's not used in the US because of the plastic anemia thing. But in South Africa, chloramphenicol ointments and drops are very commonly used. It's not a problem that we've seen here at all with anemia. And then if it's a pediatric patient, we'll use something like tobramycin. We'll use the tobramycin drop or an ointment itself. So it just depends on what the mechanism is. If it's somebody that comes in and he's got an epithelial defect, which we are suspicious of that it could become an infectious problem, we will use a fluoroquinolone or something that will be effective against gram-negative bacteria. But if he is not a contact lens wearer, we'll use a chloramphenicol ointment or a drop, no problem.
Okay, doctor. Thus far, these are only the questions raised by our attendees, and we will be waiting for a few more minutes if anyone is willing to ask.
Okay.
Okay, doctor, till now, I have one query. Like in Nepal, basically, Portugal, there is a two Portugals, like using the steroid. So we directly can't go for the use of steroid if there is a basically the epithelial defect, and we used to start a weak steroid like chloromethazone. And some of the doctors also suggest that we can directly use any type of steroid, and some of the ophthalmologists are using the type of steroid, and they directly go for it. So, what is your suggestion regarding this context?
Yeah, it's interesting that you use a steroid with an epithelial defect. You know, if there's no infiltrate with a defect, I don't really think it's necessary to use the steroid. And, you know, when I was trained in the United States in the early 1990s, one of the things that my professor said is that, you know, you don't use a steroid when you want the epithelium to recover and grow, because it delays epithelial growth and healing a little bit. And it also makes the attachments of the epithelium to the basement membrane a little bit less robust. So I would be very wary of using a steroid just for an epithelial defect. But if there's an inflammatory reaction and it's really severe, you don't really have a choice, then you have to use a steroid. But I would typically treat an epithelial defect conservatively, just with an antibiotic drop, and follow them a day later or so. And then if necessary and there's bad inflammation, I would add a steroid. But I first want to start seeing some recovery of the epithelium and closure of the defect before I use it. For instance, if you've got recurrent corneal erosion, it's not something I would advocate to do at all, is use a steroid. In those cases, we treat them with a bandage lens and an antibiotic drop just to get them to recover. We want that epithelium to heal and stick to the basement membrane, because you don't want it to come off. And as I said, if you do use a steroid, it's well known that steroids tend to delay the healing a little bit. So just be careful with your steroids. Now, you know, obviously, if it's a corneal, you know, an infiltrate with an overlying epithelial defect or an ulcer, then you can say, okay, maybe I'll use a steroid antibiotic combination to sort them out. But just be wary. Typically, if there's a defect of the epithelium, I'd first go with an antibiotic only, and then as soon as the epithelial defect heals, I'll add the steroid.
Okay, we have again another question, and the question goes as, is there any contraindication of bandage contact lens in epithelial defect?
Well, I think the contraindication is that you must make sure that you don't cause an infection. And remember, a contact lens is a nice vehicle for something to go in there and cause trouble. So when you use a bandage lens, make sure you use an antibiotic with it. And typically, I'd use a first-generation fluoroquinolone to, in actual fact, just be on the safe side. But you can use something like tobramycin or chloramphenicol as well. So I use Exocin, which is a fluoroquinolone, and just to be on the safe side, because I don't want anything that's underneath that lens or on that lens to, in actual fact, go in through the epithelium. If you think about the defense mechanisms of the cornea, there's a few things that are very important. You know, we know that the glycocalyx plays a role in attaching and getting rid of some of the stuff that sits on the surface. We know the cells are polarized, the epithelial cells, so they tend to repel the bacteria. We also know there's active defenses from the cells. They secrete proteins on the surface that kill bacteria. We know that if the cells are very strongly attached to each other, so it's very hard for bacteria to penetrate between the cells. And really, for a bacteria to penetrate the epithelium, they have to get to the bottom of the cell to really affect it, because, as I said, they're polarized. We know that the basement membrane's got small pores, so the bacteria really can't get through those pores easily. So you just don't want to put any device in the eye that might lead to a place for bacteria to reside that can then go and mess up the cornea. So if you use a bandage lens, make sure you use an antibiotic with it, just to cover that aspect of it. Remember, the bandage lens will make the eye heal. It takes away a lot of problems. If you put a bandage lens on and you've got a big epithelial erosion, it prevents the eyelid from rubbing on that erosion. So it's like a Band-Aid that you put on the eye. So it protects that tissue itself. But just be sure that you use an antibiotic with it to make sure that nothing that goes into the lens or on the lens into the eye gets to that area. And then monitor them carefully. You know, when we use bandage lenses, we'll see the patients probably every 48 hours. Have a look, take the lens out, look at the cornea, see how the staining looks. If it needs to be kept on, and we keep the lens on, and we let them sleep with the lens. They don't mess around with them itself. So we'll use a one-day lens and put it on and just monitor those patients and let them wear a one-day lens extended wear for up to a week. But we will see them maybe 48 hours in the beginning just to make sure things are getting better, and watch them carefully. And as I said, don't use a steroid with it. I hope that answers it.
Thank you for your answers, Doctor. I guess we have answered almost all the questions till now. Considering the time limits, here I announce the closure of discussion session. I would again like to express my immense gratitude for today's presenter, Dr. Dirk, and to all the participants as well. Also, I would like to thank all the direct and indirect helping hands for iDocs program. Before wrap up, I request our today's presenter, Dr. Dirk, to share his few words to our program.
Well, thank you so much for inviting me to speak to you, and it was my pleasure to do this. And if you've got any questions, my email was at the beginning of the talk. I will also make available this presentation for anybody that was on here, that they can go and look at it. If you want to email me, please email me, and feel free to ask me to help you again. I'm more than willing. Thank you so much. It's a big honor.
Thank you so much, Doctor. It's our immense pleasure to have you with us today. Herewith, I announce the closure of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you all.